is a 30-year-old male with a BMI of 40, and he has cervical neck instability from a motor vehicle accident. His height is 175 centimeters and his weight is 122 kilos. So he's undergoing an emergency X-lab today, and I'm planning a general anesthetic for him. So first I'm going to do my machine check. I'm going to check my ambu bag, make sure I have suction that's working and set up, make sure my monitor's on with the appropriate adult parameters for him, that I have my monitoring equipment, EKG, blood pressure cuffed, pulse ox. I'm going to make sure that my machine, the pipeline pressures, I'm going to check that, are at 50, and I'm going to check my auxiliary tank, make sure that's full. I'm going to look at my vaporizers, make sure that they're nice and screwed on tight, that they're full. Check the interlock system. I'm going to do my low pressure leak test as well while my machine is off. Make sure there's no flow leaks in the flow meters. And then I'm going to also check to make sure I can't make a hypoxic mixture. And then I'm going to do my O2 analyzer. I'm going to check out my CO2, make sure it's not desiccated. And then I'm going to do a high pressure test by including the wide piece and closing my APL valve and pressing the O2 flush, making sure I can maintain 30 centimeters of water. And then I'm going to make sure that I can deliver a positive pressure breath. And I'm going to look at my inspiratory and expiratory flutter valves to make sure those work. And I'm going to pre-program his vent settings to 8/5 and 40% on the monitor there. And then I'm going to make sure I have my supplies. I have my ED tube. He's going to get an 8/0 tube, and then I'm going to have size below and above for him. I'm going to have oral airways and LMA just in case. And then I have tape, my Apple's drugs, my induction drugs as well. And I'm going to be using a Mac for him. And then, so when I plan on a difficult intubation because of his cervical neck instability. So my first plan is to do a direct laryngoscopy. And then my second attempt, I'll try a fast track, and then I can also use the gyroscope as my third attempt as a video assisted laryngoscopy approach. And I'll only spend like 3 to 5 minutes on each attempt, or 3 attempts, whichever comes first. So now I'm going to go do my pre-op eval. I'm going to check my airway exam, so I'm going to do a Mallampati. He has a good Mallampati score. He is a 1. I'm going to do my thyromental distance. That is greater than 7, so it's good. Neck range of motion is not great because he's got the cervical neck issue, so he doesn't have good range of motion. His incisor gap is good. Upper lip bite test, he is class 1, so that's good. Okay. I'm also going to do heart-lung assessment, oscillotape. And I'm going to ask some of my pre-op questions. What did you have for breakfast this morning? Are you on any medications daily? Any history of upper respiratory infection? Do you have any anesthesia history, or does your family have any history of malignant hyperthermia? And then I also want to explain the procedure. I'm going to take you back to the OR, put you to sleep with my induction drugs, and then we'll insert a breathing tube in that will stay in throughout the entirety of the case and keep you nice and comfortable, and we'll remove it in post-op. Okay, so now I'm going to bring my patient back to the OR, and I'm going to start by hyperoxygenating the patient for 3 to 5 minutes with my O2 up at 6 liters. I'm going to use the EC technique and get a really nice seal to denitrogenate the patient. At this time, they already have the IV placed from pre-op, and the nurse is helping me get the EKG, blood pressure cuff, and pulse ox on. And at this point, I can push my induction drugs, and he's going to be getting 250 milligrams of prop, 50 of fent, and 120 of rock. So now that once he falls asleep, I'm going to tape the eyes, and now I can try to mask ventilate my patient. And I'm unable to mask ventilate, so now I'm going to try to insert an OPA and see if that helps me. mask ventilate with OPA, which is good. And if I couldn't get the oral airway to work, then I can always try to do an LMA, ventilate through an LMA. So now I'm gonna have my first intubation attempt since they're hyperoxygenated. So I'm going to first demonstrate the fast track. Alright, so I'm going to kind of open their mouth and then slip in the LMA. And then I'll insert the ET tube. And then once that goes through the cords, I can push with the pusher to advance the ET tube, and then I will pull back on the handle on the LMA, keeping the ET tube in place. And then I can inflate the cuff on my ET tube. I was not able to get the ET tube through the cord, so this was a failed attempt. But for the purposes of this video, I wanted to demonstrate the skill. And then, since that didn't work, I'm going to optimize my oxygenation in between my attempts, and I'll have a second person helping me with that, maintaining oxygenation. And then I'm also going to be monitoring my end-tidal CO2 in between attempts as well. So if I can ventilate and I can't intubate, my approach is going to be to look for alternative options, like I can use the video-assisted laryngoscopy, fast track, retrograde intubation, or the fiber optic scope. And then while I'm doing this, I'm going to be aware of the passage of time and optimizing my oxygenation and limiting my attempts, and then checking my end tidal as well. So now that someone's helping me with optimizing my oxygenation, I'm going to move on to using the glidoscope. And the glidoscope is really great because it has the camera for better visualization, and then also has the lens that's heated so that it doesn't get fogged up. And then it has a hyperangulated blade as well, and also doesn't require the sniffing position for my patient. So I'm gonna make sure I have my 8.0 tube here. I'm gonna insert the blade midline. Once I get it past the teeth, I can look at the monitors and start looking at airway structures. And then I'm going to lift up and visualize my airway structures. I can see the corniculates, cuneiform, and the cords here. Now I'm going to insert my tube on the side of my patient's mouth into the back of the oral pharynx. Once I get it through the cords, I can remove my stylet, and then I'll advance it just a little bit further. Okay, now I'm looking for bilateral breath sounds. I'm going to auscultate. I can see misting in my tube already, and then I'm looking for end tidal to confirm that I'm in the right spot. I'm going to tape my tube down and make sure that the distance is appropriate. It's going to be at 24/7 years for this tube. And then I'm going to turn my SIVO up to 4% at this point, and have my vent settings that I've pre-programmed on there that are appropriate. So if I were to get into a situation where I can't ventilate, can't intubate, first I need to call for help and I need to act quickly, and I'll continue to look for alternative approaches for securing an airway, and then I need to be preparing for an emergency invasive airway if those don't work.